But actually we're going to have you roll up your sleeves and really spend most of the next hour talking to each other and sharing what you know of available resources, things that have worked for you. As Una indicated this morning, a key objective of this work is to develop a toolkit, a set of resources that will be specific and useful for you here in Ireland. And so what we want to do in this session is hear from you what you might know already exists. And so certainly in my world, what I've seen over decades is that as each person gets into this field of knowledge translation, we've tended to go and create a tool, not necessarily realizing that there may already be one or two others out there. And a really good example of that are around the knowledge translation theories, models, and frameworks that exist. Someone said that earlier. There are many, too many that are out there. A few years ago, someone had done a systematic review and at that point had identified 66 models and frameworks, but I'm sure that work's about 5 years old now, so that number could easily be 100. And what people have tended to do is they might have found some and thought, well, my area is unique. And so we need to, it might have been something that didn't quite cover everything, so then they created, a new model that's a slight variation, or it could be something that's quite different. So that exists really across the board with all sorts of resources. Although that's not necessarily a bad thing, knowledge translation is still a new and evolving field. And there's still a great deal of work, as I was saying this morning, around developing different types of resources or measures or things like that. So it's not bad that, many folks around the world are working on tools, but we really do need to be thinking about how can we share those tools and be testing them in different areas and tweaking them. So I'm going to show you a variety of resources that we have, and one of the things that we strongly encourage is for folks to use these tools. Some of them we've created, some we've found that others around the world have created, but we really want people to use them and adapt them, modify them to be relevant to the contexts and settings that you work in, and then send it back to us so we can put it back into our repository so that other people can access them and tell us how you've changed them, those types of things. All we ever ask people to do is to just acknowledge the original source of that tool, say adapted from, so that we can always give credit back to whoever it was that created those. So one of the things that my center was funded to do was to somehow compile resources that are related to knowledge translation. And we actually were given our name from our funder, the National Collaborating Center for Methods and Tools, which, while that brand now seems to have, is known in Canada at least, still many would say, what is that? What does that mean? And actually we spent the first few years figuring out what that meant in terms of the people, our public health partners, thought that meant methods and tools for anything related to public health research. So they could come and find different types of measures for anything. Could be well baby visits or something related to immunization. But actually it's what we settled on as our mandate was casting a net around knowledge translation methods and tools. And some of those tools can be generalized to program evaluation in public health in terms of the process, but really everything that we've tried to assemble is methods and tools related to knowledge translation. And so there's a variety of things that we've created over the years. And one of the things to keep in mind, if you have been to Canada or recall my map from this morning, it's a very, very, very large country. Actually, haven't flown coast to coast, but some of you might have if you've ever gone through to Vancouver. I think we have at least 5 time zones, east to west, maybe more. And so there would never be adequate funding for us to visit everybody with the personal touch to develop capacity. There could never be enough money for us to be able to do that across the entire country. So everything that we've created is freely available online, so that everyone in Canada has equal access to that, which then also makes it equally accessible to anyone around the world. So it's all there for you to use. It's available in English and French, as those are both official languages in Canada. And so these are just resources that you can access at any time. And so when we really started developing our work plans in the early years, we really started thinking about our business lines. So what are our products? At the top here we have our registry of methods and tools. I'll talk about in a minute. Then we moved on to what type of online learning opportunities. So we can't go out to everybody face to face. So what can we create online for them? And certainly you may have experienced this over the last 15 years or so, but Canada has definitely had its highs and lows with respect to funding for educational purposes. A lot of those budgets have been cut. So the frontline public health nurse or manager, really, unless there's a conference going on or some kind of an educational opportunity in your very city, there aren't the resources to travel across the country to go to those. So we created a variety of online learning opportunities that they can access. I'll talk quickly about that. We do go out and provide workshops. I'm not really going to talk about those today, but you could find, we have quite a large variety of workshops that we tailor now to what the needs of an organization are. Various knowledge repositories, I'll talk quickly about that. Molly mentioned health evidence this morning. And then multimedia and knowledge brokering are just a few of those. So I'm going to start with our online learning modules. And one of the things I didn't show you this morning, I showed you our evidence-informed public health model, the concentric circles, but another framework that guides what we do is a 7-step process to evidence-informed decision-making, which starts with defining your question, searching for the relevant evidence, knowing that evidence is the best available. So how do we know if something is good enough to inform our practice? So critical appraisal, synthesizing the evidence, assessing its applicability to our local context. So Ireland is probably similar to Canada in that, in the grand scheme of research going on in the world, Canada produces a very, very small amount of that research. And if we only use the research done in our backyards, we would have almost none to inform our practice with. So that means that we need to approach research that's been done in other countries as it's likely applicable in my setting, and unless I can prove that it's so different, it's been conducted somewhere so different from Canada that it really won't apply. But generally what we need skill in is in thinking, how do I take this research evidence that's been developed in places other than Canada, maybe with different health systems and organizations of care, and think about how it will apply in my local setting. Although that could happen, we could do research in Hamilton, and Vancouver will be thinking about, well, how do we apply that? Or maybe Thunder Bay or a small town in Newfoundland might be thinking, how do we take something that was done in a large city and apply that in a small urban, small rural place? So assessing applicability, transferability is really important. And then if we want to actually go about changing practice, well, how do I do that? We've made a decision in my organization, we want to do something different, but now how am I going to get everybody to actually do that something different? So an implementation plan, and then how am I going to evaluate that we are in fact doing that thing differently and that we're hopefully achieving whatever outcomes. So this is a framework that guides all the work that we do at NCCMT. And what we identified along the way is that there's specific knowledge and skill that you need in order to do all those steps. And that there are resources that may help people gain those skills. So one of the things that we've created is an online, a suite of online learning modules that take people through all of those steps. And for some of those steps, we have multiple modules that folks can access. They take somewhere from 2 to 4 hours to complete. There's a pre-post knowledge test and a pre-post self-efficacy assessment. And upon completion of the post test with a 75% correct response rate, then you can print out a certificate of competence in that particular area. So there are about 13 of these modules that, again, are all freely available for anyone. You can go home tonight if you're so inclined and sign up and start using them right away. Well, we also did just about 6-7 months ago, we actually worked with McMaster University's continuing education program and actually accredited 6 of these modules. So you can now sign up to take these 6 modules through McMaster University, and when you complete those 6 basic modules, you actually get a certificate from McMaster University of competence in knowledge translation and public health. And we've actually been really thrilled with the number of people that have signed up to do this. There's very small, minimal cost. That really is just part of the cost of, well, actually, I guess what I've learned is when things are free, people think that they're not very good. So we actually have a little small charge in there, and lots of people have been signing up to do them. So just something to keep in mind. They're not the only modules. A colleague of mine, Melanie Barwick, who works at Sick Kids Hospital in Toronto, has a different suite of modules around knowledge translation. These ones are really great for students, graduate students, and practitioners working in public health. I wouldn't say are quite as focused on what the needs of a researcher is. Melanie Barwick's a little bit more focused on what you need as a researcher. So that's just a little bit more about the types of modules that are there. Something else that we created, started creating a few years ago, after years of working with public health professionals, we would run a lot of workshops that would take them through critically appraising different kinds of evidence. So critically appraising systematic reviews, qualitative studies, best practice guidelines, and always in those workshops we spend time going over interpreting results, and in particular quantitative results. And over those really, I don't really want to say 2 decades, but it kind of was. 2 decades, because that really ages me. But I saw the same uncomfortable looks every time we brought up those forest plot. And we saw one of those earlier today that showed the no effect that Anne had on one per slide. So we would quantitative results of relative risks, odds ratios, confidence intervals, things like that. The zebra photo, heads down. Don't call on me to say what the interpretation of this is. And I thought we need to do something about this. You don't need to be a rocket scientist in order to be able to interpret these findings that are in a lot of the public health literature. So what can we do about it? So we have reached out to the public health community to tell us what are the terms that concern you the most, that you feel most uncomfortable with, because one of my goals became I want that to be the part they rush to read in a research article. I don't want to skip over the results or the tables. I want them to take a look at it and have the confidence to know they can figure out what that means well enough to get the gist of it, as opposed to doing what do many people normally do when they read an article? Read the abstract, jump to the discussion and conclusions. Let the researcher tell me what I need to know. I want them to come up with their own conclusions. So we started creating these, we call them UREs, Understanding Research Evidence videos. And we've worked with a media production company and a really good editor to take my research jargon of trying to explain different kinds of terms, putting that into really easily accessible lay language, and creating those around very relevant, pertinent public health scenarios. So this one here is about promoting the flu shot, and it's talking about an odds ratio of an intervention to get the flu shot, things like that. And so they're all short, they're less than 10 minutes. The goal was to keep them more around 5 to 7 minutes. A few of them crept up a little bit. And have to say, if we just went by hits alone, this would probably be our most effective project or product that we've created. They've been watched tens of thousands of times, different ones. Now there's nothing better than putting yourself out there, because the more people hear about them, the more I hear from statisticians that they really don't like some of the things that we said. So we have to deal with those as we go. But to me, it's all around what's good enough to help public health folks understand the evidence that they're reading. Some things are really technically difficult to say correctly without using more jargon. So we'll be trying, for some of the statisticians that are currently very upset with me, asking them, work with me to help me say this in a way that is simple to understand. So something that you could look at. I think there's around 13 or 14 of these. They're not cheap. They're actually pretty expensive to make, but I think having that good quality is really, really important. And what we did was we kept on going back to, we created these over about a 4-year period. The topics were informed by what public health folks told us was interesting. They aren't all quantitative stats. Some of them are around what is evidence-informed decision-making and giving them different kinds of examples, or the 6S pyramid of a hierarchy of synthesized evidence, explaining what that is, different things like that. So something, again, that you can take a look at. The Rapid Review Guidebook, something we just recently released. So what we were seeing in Canada was that many public health organizations are now taking science into their own hands, doing their own rapid review. So it's not a full-blown systematic review of the literature. They don't have time to wait for that Cochrane review that takes 2 to 3 years to come out. They're doing their own. So most health departments that I work with are doing their own rapid syntheses of the evidence. They're all doing it a little bit differently. So we created a guidebook to actually step by step take them through the process from start to finish, even with some direction on if your organization wants to move towards writing a report, a short report, what would go in each of those sections, how long should it be, keeping in mind this is not an academic exercise, it's creating a report of what they did and even some decisions that were made from that. So trying to keep it as tight as possible, and also it provides a record for the organization of what they did, what was done, so that if they revisit this program or decision a few years from now, they actually have somewhere to start from in terms of what they did. Again, something that folks are accessing. This was only launched about 4 months ago, and many people have already now been downloading it. Interestingly enough, when we talk about the return on investment, being able to demonstrate to my funder this was a good use of resources versus making something really useful for my audience, we have put it up on the site in a way that allows people to click on the link and fully download the PDF to their desktop. Now that isn't the way I really would have liked to have done it. I would have liked to have forced them every time they want to use it, come back to my site and click on the link to open it and look at it. But what would that do if I created it that way?
Multiple hits.
I would get lots of hits, which is great for me, but not great for my user, and they probably wouldn't come back again because they'd be mad at me for doing that. So, it's most important that they have what they need. What does that mean? It means that I know it's being used a lot more because one organization, for example, told me we've now put this PDF on our intranet, and there's 600 people that might be accessing it multiple times in a year in that organization. So all I can do is go back to them and say, is there a way you could track downloads or usage or something? But essentially we're just able to pass that information along to our funder. Again, this is something that it was, I would say, primarily from interaction with my audience, with public health, and seeing and observing. So exactly what you were talking about, Emma, this afternoon, is really listening and observing and seeing what's happening allows us to start to think about what needs might exist, and then actually reaching out to people to say, well, if we created something like this, would it be useful? And sometimes that works, doesn't always work. So these are the kinds of things that it goes through. So again, just like the steps of evidence-informed decision making, these are all the things that we walk people through in the guide. Something else we created a number of years ago, again, in partnership with a health unit that had contracted us to put a knowledge broker in their setting and to help them work through using evidence in practice. We created this briefing note that actually takes one through articulating, so what was the question we were trying to answer? And I'm happy to provide the slides so that you can send those out. So what's our research question? What is the issue? What's the problem we're trying to answer here? It's an opportunity to add in some of the local data around what the issue might be. What's the current status? What are we currently doing about this at our health department? It also allows in a table to then summarize what the findings of an evidence review, of a rapid review might be. And on the back side of this, it then identifies recommendations for practice and then what a final decision might be. So it actually gives, in 1 to 2 pages, an account of what happened on a particular project. And again, we really work with health departments about developing a knowledge management approach so that this doesn't get lost in someone's computer. So that the intellectual knowledge that was gained through this work can be stored somewhere for others to check. One of the things that we've learned from doing various kinds of workshops, you may have the same issue here, it's really 2. On almost any workshop that I've done, I'll happen to probably go off on a tangent and start talking about, such and such health unit. I was just talking to them last week, and they're embarking on a rapid review on X. And there'll be at least 2 people in that room from other parts of Canada saying, we're doing that too, or we're just about to do that, and so part of our job is to help connect people, because very similar issues exist across the entire country, and multiple health departments are doing their own syntheses at the same time or near the same time. And wouldn't it be better if we could get them to work together or share them? That's part of what this does. In an even more, I guess, dire circumstance in some of our larger health departments, we might even have multiple groups within the same health department answering the same question, and they don't know that they are. So this type of an approach might help to diminish some of that kind of duplication. We have way too many questions to answer to spend time with people answering the same questions. This here is a tool we've created, and we call it the A&T tool, the Applicability and Transferability tool. And there's 2 versions to this tool. This really, there's nothing rocket science on this. What this tool does is it takes decision makers through just in a kind of linear fashion, questions one would ask that you'd want to know about if you have made a decision to start a new program. So we looked at the evidence, and based on that, we want to do something new. This takes you through, okay, what kind of training needs might you have? Do you have the staff in place that know how to do this? Do you need to reallocate anything? What do your community partners need to know about this? So it really takes folks through. And generally when I have folks work through a tool like this, they tell me that they've used a lot of these questions in program planning before, but they haven't seen it in this kind of neat little package that walks them through. So there's one version of this tool if you're starting something new. There's a slightly different version of this tool if you're de-implementing something, because there are some different issues there to consider. We have had a few instances where, on one end, it's complete success in that a health department has, gone right ahead, they're into evidence-informed decision-making. They've looked at the evidence and decided, okay, this program doesn't work, the evidence says it doesn't work, and we're just completely cutting it next week. One health unit did that with smoking cessation quit and win contests. After 10 years of being funded by the provincial government to run quit and win contests, they reviewed the evidence. At that point, the evidence wasn't looking like it was overly effective with long-term quit rates as well. It only touched us, that didn't have the reach that they wanted for their population. So they basically gave about 2 weeks notice to the team that had been doing this for 10 years and said, we're not doing it anymore. So that caused a lot of upheaval in the health unit, as well as among community partners who they had been working with. So this would have, if they had used this tool, they might have said, oh, wait, maybe we better work on a few things first before we de-implement. So this, two versions of this tool can be really useful. Someone has now taken this tool and modified it to bring in a health equity perspective. So it really addresses many questions one would want to be asking in terms of if we add something new or take something away, might we inadvertently widen the gap in health inequities as opposed to reduce those? So another tool. This one I mentioned Melanie Barwick. So she's spent a lot of time working with researchers and others around how to go about developing an implementation plan. This is a slightly older version of the tool, but here just looking at who are your project partners, what kind of engagement are they going to have, what are their roles going to be. So really, a way to have something very tangible to go and sit down with folks and actually talk these things through, something that helps cue you to the kinds of things that you can be talking about as you work on an implementation plan. And then something relatively new, our Public Health Agency of Canada a few years ago came out with core competencies for public health. So the core competencies that they expect all public health professionals in the country to have, and a fair number of them are related to evidence-informed decision-making. So what we did was we created an interactive page that would allow one to search through the competencies, and from there they can, we've mapped onto those competencies any resources we have at NCCMT, at the National Collaborative Center for Methods and Tools, any resources that would help you gain competence in that core competency. So we started with just mapping them to our center, and we're just about to roll out the mapping across all 6 centers in the country, mapping resources that would help gain competency across the board in this. So again, something that's freely available. This is just a little bit about what it would look like. They clicked on one around implement a policy or program, and these are some of the resources that have come up to help that one can click on to do that. So this is health evidence, and just a slight tweak from this morning. We used to be healthevidence.ca, but changed that to .org. It was interesting after almost 10 years of being in existence. because of the .ca, folks thought that that was really just a resource for Canada. And so we finally decided we have to do something about this because it's a resource for the world. So healthevidence.org is a repository of, they're not all systematic reviews, but reviews, literature reviews, evaluating any intervention relevant to public health in the published literature. So it doesn't include anything outside of the published literature, and it only includes reviews that are evaluating the effectiveness of interventions. We critically appraise the methods of all of those reviews, and it's all freely available in this searchable database. And you would get from that, if you went into this and put in breastfeeding, for example, you will get all of the reviews that have been published on effectiveness of interventions to promote breastfeeding, as well as the methodological quality assessment right beside it. And we do lots of other social media mechanisms to push this information out to folks. So again, it's freely available. You can come on. You don't have to. You can create a profile. With a profile, you can set it up to receive monthly email alerts, and you could put in, I work in physical activity with children, and on the first of the month you would get an email from us with any new review added in the past month just on that topic. So you can keep it broad and get anything. We usually have about 40 to 60 new reviews a month that are added, or you can specify vary by topic what you'd like to receive. We do regular webinars. Now they probably hit you near the very end of your day. So normally our webinars are around noon, my time, so that's Eastern time. So it'll be about 5 o'clock in the afternoon. Except we realize there's a couple of weeks where Canada and Ireland are 4 hours apart and not 5. When we had a meeting one time booked. When we go ahead a few weeks, I think, before you. So again, a repository that may be really useful in terms of for your own work or in pushing out to some of your stakeholders. And another one that I've been working on, and this comes back to a question that was asked this morning about patients. We've been, at McMaster, received some money from Suzanne Labarge about 6 years ago, and we've developed a portal for citizens in Canada. And so this is, how do we focus on how do we promote optimal aging amongst those 60 and over and the people who care for people 60 and over. We started there. And what this was is the health evidence repository I just showed you, that's for public health. A colleague of mine, Dr. John Lavis, has a very similar type of repository that has compiled evidence on health systems, all critically appraised. And another colleague, Dr. Brian Haynes, and now Dr. Alfonso Iorio, has another repository that is filled with clinician evidence, all critically appraised. We all are at McMaster. We actually are all in the same faculty, although we're in different departments. We all do the same kind of knowledge translation work with different audiences, but we're not connected. So what the portal did, with the funding from the portal, you can now, with one click of a button, search our 3 databases at one time, and the portal will illustrate. So let's say our funder always wanted to see something. She wanted to know what was going on with cataracts. What do we do about cataracts? So if you put that in there, you would get what are the results. Is there anything in health evidence, in the policy, in the health systems database, in the clinician database? And furthermore, we've been creating new products for citizens. So writing blogs. So trying to now take the evidence that really, frankly, if you're not a researcher, maybe policymakers and decision makers, but who else wants to read research articles? Like, not many, right? They're kind of boring. So we've been experimenting with how do we distill health evidence, to the public in a way that's engaging, that will help them think about behaviors they can engage in for optimal aging. And now we've been trying to do some evaluation of the portal. And then lastly, I'll just talk about the registry of methods and tools. So we, as I said, we searched the world, both literature, the published literature, and in the unpublished world, looking for tools, looking for organizations that are involved in knowledge translation, whatever term you want to use, knowledge transfer, knowledge translation, knowledge mobilization. In the US, they call it dissemination and implementation. So we've searched the world looking for tools that folks are developing. I certainly believe that most tools that exist are relevant to public health. Not all of them. Some of them are very, very tertiary focused, but most of them can be generalized to public health. We take a look at them, and if we do think that they would be relevant to public health, then we're compiling them in an easily searchable repository. So all to say that, as efforts are underway to develop a toolkit here in Ireland, here's something that already exists that you can go home and at any time access and see what's there. You can put in keywords, or we have a drop-down menu of things that you could search on. But now we want to move towards what's unique to your needs here in Ireland that will really help you to go from, this day of lots of great stories that have been shared, but how do we keep that momentum going? How do we make this real about, how would I do this when I get back to work tomorrow or on Thursday? So this is the putting you to work now. What I'd like, how much time did that?
It's 10 past
Okay.
now, so
I
maybe.
didn't realize I spoke that long.
Yeah.
Okay.
20 minutes in total
Okay.
left.
Okay. So what I'd like you to spend 10 minutes talking about, and you could just turn to the people, so you guys turn to the people behind you and you guys turn back there. Talk about what types, are there any resources that you know about right now that you'd like to share? Because we want you to write these down on the Post-its that you've been given. And Una is going to be collecting all of those. So what types of resources do you use or know of is number one. And the second is, what do you need in terms of tools or resources that would help you, either yourself doing knowledge translation or doing research in this field or helping others do research in this field. Is that clear?
Yeah. So it would be really good if you wrote 1 down to the and 2 on your Post-its.
Oh, yeah, right.
That would
Sure,
be
yeah,
good.
good idea,
So
yeah.
1 for the tools you know of and 2 for the
What your
and
needs
what
are
your needs are. That would
in
be
relation to that.
being a bit selfish about it.